I'm Patricia Thaine, co-founder of Private AI, and this is the Data Frontier podcast. Here we explore the frontier of data innovation where unstructured data meets real-world applications. Each episode brings together builders, engineers, data scientists, product leaders, and domain experts who are shaping the future of intelligence systems. From NLP and privacy to interoperability and AI-driven workflows, we unpack the tools, challenges, and breakthroughs transforming raw data into smarter systems, faster insights, and better solutions. Adam and George, thrilled to have you join us on the Data Frontier podcast. Thank you so much for being here. Adam, could you go ahead and introduce yourself, please?
Yeah, a pleasure to be here, Patricia. Thank you for having us both. Adam Cole, I've been a digital health leader, executive practitioner for my entire career, which is north of 25 years. I stopped counting around there. I've led innovation for some of the largest healthcare companies in the world, like McKesson Canada. I've been VP of IT at the Canadian Clinical Trial Network. And more recently in my career, I've transitioned into what I find far more exciting, which is the world of startups and smaller digital health-oriented companies.
Thank you for that introduction. And George?
Oh, hey, I'm George Smitherman, perhaps best known as Ontario's Deputy Premier and Minister of Health for a long time with Dalton McGuinty. Perhaps last heard of for losing the mayoral election in Toronto to Rob Ford. Forever curious and delighted to be in the space of AI with two subject matter experts. I'm 61 by now and really trying to figure out the way to stay current rather than falling behind, because I can see obviously that there are going to be divides that occur even within organizations. I can start to see it with AI literate and not. So I'm not literate quite yet, but I do drop it into sentences 6 to 12 times a day just to seem as though I am up to date and timely, whether that's with customers or just friends. So privileged to be here and to challenge some of the knowledge that you have with some questions that I have to ask as well.
Thanks so much. It would be great if you two could start by telling us what some of the biggest challenges you see in healthcare at the moment.
Quite interesting amongst the peers that I'm working with, which in one enterprise are all 60 or over. The one really, really strenuous point of continuity is the extent to which they are expending energy with later in life family members, many of whom are in pretty chronic need of assistance, etc. So I think that's one of the things that I see out there for the healthcare system. I think in the face of the demographic pressures, what we see is largely what we're going to get if we're lucky. And I hate to sound like that's not an optimistic take on things, because I'm witnessing for someone close to me a cancer journey where I'm very impressed with the performance, in this case, of the Hudson Regional Cancer Center at Royal Victoria Hospital in Barrie. And I've heard other experiences that people had with loved ones with cardiac events through Kingston and into rural parts of Eastern Ontario. But I think that, when I look at the frailties, I want to just kind of like put two things out there. The first is to say the doctor shortage and the health human resources shortcomings that we have now were predictable, haven't been proactively headed off, and are going to be very, very difficult to catch up to. So I think that when I said a minute ago that kind of what you see is what you get, I do think that the health human resources challenges, especially measured by physician shortages, is going to be a reality that we face for the next couple of decades anyway. There are heroic efforts being made to expand the size of medical schools, etc., which I fully applaud the current government for. We're starting to see some of the efforts at getting practice-ready doctors faster and into service, but there's still a lot of pain and shortcomings that are out there. I think what that tells me is that we have to look for all of the places where we can enable healthcare performance and access to information and access to services for our 14.75 million customers in Ontario. Is how can we use technology and deploy it in a fashion where the patient sees it as beneficial rather than it gets characterized as cost cutting. Like, I think that this is the evolution point that we are at, and I think it's very, very exciting if we seize onto it. It's really a time for very profound consideration of what's possible and trying to shake government and governmental control, command and control freaks, to try and shake them actually a little bit out of that, to say, are you at risk of missing leapfrog opportunities that are presented by the current situation with respect to AI, as an example? And of course, Patricia, what drew me to speak to you was my keen interest around the appropriate protections of my personal health data in that context.
Great points, George. And it's, I just want to pick up on what you're saying, because I agree with every one of them. And I think a common thread is, you and I have both been in this space for for a while. The issues remain the same for the most part. Cost containment, costs in the healthcare continue to outpace the inputs, the elderly population, the demographics, as you were speaking to. We've been talking about that as a trying to stick a pig down a garden hose, and we're just getting to that point where the costs and the management of elderly populations of the baby boomers is really going to be a significant hit to not just healthcare, but to a number of different social services. And so making sure the dollars are available and spent as best as possible. These are all long-term issues, and doctor burnout, that's another long-term issue. Interoperability of healthcare records, you were also talking about. As we talk about interoperability, the flip side of that, of course, is the privacy considerations. These have all been issues that when I started my career were also issues. I think that the big difference today, and I hesitate saying it because I've been saying this my entire career, the big difference today is technology. But I can say that with a straight face today because AI, I absolutely believe, is a game changer. And I know 25 years ago, I said that about the web and the internet, and I believed that at the time. But today, with absolute conviction, AI is going to play a significant role in addressing these concerns. And I think the biggest obstacle for healthcare in adopting AI is that the challenge we have perennially had is change management and adopting new technologies.
I bear reputationally some of the criticism for that very point with eHealth, where we spent a lot of money and didn't really get very, very many gains for it. And already the culture of the government of Ontario with respect to big technology projects was very blemished, from the Accenture rollout of the Harris years, and I think also some big projects related to justice, bringing various things together. I worry that it's actually culturally built into the mix of the Ontario healthcare system. I think what's going to be very interesting going forward is there is a lot of healthcare which is publicly delivered, and there is a lot of publicly funded, privately delivered healthcare. And I do think that the opportunity for innovation, where you don't have to ask permission of the ministry, is in a certain sense better positioned to succeed, and in some cases probably to fail, with more ambitious technology plays, if I can use that word. And when you think about and a lot of people will be troubled by that, because a lot of people like to pretend that private delivery is two-tiered healthcare, which it needn't be. Some of it is, and getting away with it, that's a different matter. So I think that's going to be very interesting to watch going forward. As an example, we know that there was a celebrated situation quite recently where Ontario procurement had shortlisted the vendors that can do AI scribe for doctors. And we know that doctors, it's ridiculous, right? They're very highly trained and quite or very well paid, depending on your perspective. And to imagine that we have created a system that more and more and more absorbs their time without consideration for the implication of access for other patients, like Ontario Disability Support Program for a patient, more than an hour. The new federal disability credit, like someone told me, like 45 minutes, etc. And that's a huge thing. But my real point was, we celebrate that AI scribe. Well, other places would say, well, that's rather middling. Like, obviously, yeah, like, what else are you getting onto? Yesterday, I saw something on this point of interoperability from Epic, where they're not just going to play AI to large databases, they're going to play AI against my actual situation, and I think there are some privacy issues there for sure. Patricia, you'll see those obviously, but the potential of that also really tickled my fancy. On interoperability and privacy legislation, I was the author of the redo of the legislation, which has since subsequently had amendment. I spent a lot of time looking at the matter of privacy on a personal basis, as an example, where in the organization where I get my healthcare, my file, I keep it on private access because I'm not interested in people snooping, and it's always possible. Some people got caught snooping in late Mayor Rob Ford's medical record, and that's sad and disheartening. But my real point on interoperability is that when I was doing any work on that legislation in consort with Dr. Ann Kavukian, still a very, very well-known and regarded and outspoken person with respect to privacy, we certainly didn't imagine that the circle of care was designed to create a model where it ended at your doctor's group and couldn't cross over to your local hospital, etc. So I think that maybe that got off track, or maybe subsequent legislation changed it, or maybe the intent was never made perfectly clear in the first place. But to have a situation where we have at the hospital emergency room this model of catch and release for old people is disheartening. And I saw my mother go through it, where time and time and time again, they'd ask her the same questions, or they'd be yelling at her in a name that was on a file, but that she didn't use or recognize when she was in a post-brain aneurysm state, etc. So I've seen some of this in practicality. I was there and had the privilege of passing legislation, one of 10 bills that I had a chance to pass during my time there. And I know what the intent was, and I'm really, really disheartened by that challenge. On the other hand, my last point here is I've witnessed up close and personal now the interoperability of healthcare systems in two different parts of Ontario, and it's rather remarkable how different they can be. And I really mean a for better and a for worse situation. And some of it really left me seriously disheartened, that the docs have their certain power around their EMRs, and they all get special, clubs around this one or that one. And that means they don't want to see the local hospital implement situation X, or the nurse practitioner led clinic is on a totally different stream, etc. So there are still a lot of opportunities for improvement, let's say.
Oh God, George, it's so hard to follow you. That was brilliant. I want to I want to reframe something you said early on there, about eHealth Ontario. The intent and the ambitions of eHealth Ontario were excellent, and your heart was completely in the right place. It was about digitizing and creating an interoperable healthcare system to better healthcare outcomes for all Ontarians. So I'm actually quite proud to stand beside you as a colleague and a friend in what you did there. I think it's worth a bit of a foray, though, into what the issues were. You talk about some of the challenges around the implementation. You mentioned Accenture, and we know CGI, I think double cost overruns with the NHS in the UK. And I think it was CGI as well who did the rollout of the ACA portal in the US that didn't go so well. But we know the motivations. Healthcare's huge, huge dollars. And these large implementation projects stand to make many people rich. So incentives, motivations, they always drive behaviors and not always the behaviors that are in the best interests of the larger social fabric. So strong governance is important. And that raises an interesting dichotomy. On one hand, we want innovation and we want to move quickly and adopt technology, and I'm all in favor of that. But on the other hand, we want the strong governance, because as we talk about PPPs, public-private partnerships, and involving large organizations, there's a very strong motivation for them to look after themselves rather than the objectives of a social healthcare system. And the best counterexample to a productive healthcare system is just to the south of us. And I'm sure everybody who's listening to this knows the big facts. It's effectively a little more than 2 times the cost per capita with lower health outcomes. And we're starting to see now with MAHA, the Make America Healthy Again,
Rhymes with ha-ha.
yeah, yeah, significant erosion of those governance controls in the interest of innovation. And I'm not saying that it's all bad, but we have to definitely keep a careful eye on that. The other point I want to pick up on that you mentioned too, because you talked about Epic and the AI that they're using and the scribes here in Ontario. I just read something recently. I think it was from Brendan Keeler. So I want to give it the proper attribution here. He was explaining the difference between AI scribes and ambient technology. And I'm not going to do it justice, but I really like the separation where AI scribes require active participation with the scribe. Ambient technology just listens in the background and has the intelligence via the AI to understand who's talking and what the intent of what they're saying is, and then to provide the appropriate interventions via clinical decision support or suggestions of medication orders or what have you. The evolution of technology can be so impactful. Anyways, I do believe that Epic also just announced earlier this week that they're going to be introducing ambient technology.
I think in the last day or two, they launched 3 different portals for groups to access their AI engines. They all had first names of kind of Northern Europeans. I think the people-facing one is Peter or something. I can't quite remember them. But the point was really influenced for me. This point was influenced a lot by Patricia. And when we met the first time, some nice person introduced us, etc. And I'm always happy to meet new people because I always have a lot of questions. And actually, stemming from that, and in later conversations that I took up with Adam, I really was inspired in a sense, at least in my mind so far, and a little bit on paper, to recreate the doctor's office for the future. That we have a very interesting phenomenon in Canada, which is doctors' offices are, largely speaking, private enterprises. Like, a lot of people don't want to think of it like that, but most of the doctors are. Now, not if they're practiced, like not all of them, okay? And I helped to create family health teams. Some of those, but many of those doctors are running their own businesses, clinics with overheads and all of that. They're not interested, as best as I can tell, in the overheads on the go forward. That's gotten to be quite a nuisance, alongside the nuisance that they have also of 17 hours on average of administrative burden, etc. So we have all of these established physical places across the country where the people working in them might wish to continue working, but don't really want to run them anymore. And to me, there's a really, really big opportunity for a next generation play on the doctor's office. And, I conclude, I kind of coined the phrase that after I talked to you that, your electronic medical record or health record, your EHR, EMR, call it what you want, is your continuity of care. It's, I think, going to be more and more enabled by technology, like the way AI can interface with that, like I was mentioning with Epic. But I think it's going to require, as you made the point also, is like there are risks to data, and you have to wall off appropriately to strike that right balance, because I would love to imagine a medical practice where if people were signing and rostering to be a patient there, that part and parcel of that was a significant consideration and consent for participation of their non-personal data to be used in research, etc., which I think is advantageous broadly for discovery. And Adam knows a lot about that from his work at the Clinical Trials Network. But to actually kind of like next generation office where it is significantly aided by technology to the benefit of the patient. And I think that there's a very significant opportunity out there. And one of the risks that we face for those people that don't like the private in our universally accessible, publicly funded healthcare system is the venture capitalists going into that space. They're already there, but actually taking over that space. If you like the way that worked at your veterinarian clinic, put up your hand, because a lot of people probably didn't, because it's notably different than before, let me say. The price, still horrendous, notably different in the feeling, etc. But there's a really, really huge opportunity there, and I can't stop thinking about it.
Okay, I want to pick up on that. That's interesting. And I have a question for you, George, but I'm going to frame it first. Through my own personal experiences, one of my big frustrations with primary care is my daughters are older now, but when they were young and, they'd have coughs and colds, and it's you spend all night being awake with them, and in the morning you want to take them to see the doctor, and you can't call the doctor's office ahead of time to get an appointment. You have to wait till they open at 8:30, and then it's a frustration on the phone, and then you finally get through to them, and and you have to take half a day off to bring them into the office, into the doctor's office, when quite often uh, we're used to self-serve models in other aspects of our life. And another personal frustration is I've got anemia, low blood iron, so I get regular lab tests for it. And my doctor knows this, but I cannot get the lab tests emailed to me. I have to go into the doctor's office to pick up the lab requisition and then take it to the lab. And why can't that be emailed to me? I know why. It's because of cost. The doctor gets paid for me coming into the office, not for sending me an email. As we start to think about your vision for the primary care clinic of the future that's based on a lot of these technologies, let's dive into the obstacles for a minute. In your mind, what are the big obstacles that we have to overcome?
Well, I think, one of the elephants in the room here is that the doctors have retrospectively, I would say, because I inherited this model from the conservative government and I didn't change it because the OMA is a very powerful interest. So we could talk more about that, but that's really in the deployment of electronic medical records on an inconsistent basis is a real limitation in terms of getting systematic performance. Now, that's because those offices are private. It's just like I was mentioning a minute ago. If you look at the operating, that's an operating cost, to Adam's point, is like, it wasn't, then the government put hundreds of millions, if not $1 billion or more. I don't know how much exactly, but I think on my watch, quite a bit of money out there for physicians to implement EMRs. But there's like 30 or 40 different providers. I know many of them, and one is lovelier than the next and smarter than the next and does something better than the next. But, I hear a debate amongst frontline doctors about the one that they like because it's on one screen that saves them from having the debates that they get into around the differences here and there. It's a real struggle to get systematic performance when you have so many disconnected fragments of delivery. So we say healthcare system, but I use the tortured expression as minister. The more of a system I look for, the less of a system I see. And it remains in primary care tremendous territory for improvement there. But doctors on a one by one basis are strongly empowered on this point. And as much as we love them and we want more of them and we love them, in case they didn't hear me say that we love them, they can be an impediment to progress without knowing it, really. There's a lot of territorialism at play, etc. But there's a big opportunity there, I would say, overall. I think that to your point, Adam, if your kid didn't have a busting fever, then I have to ask, like, if it was just a cough and a cold, as you said, is like, no, don't go to the, like, what is the doctor going to do? People want to be dispatched with some antibiotics that actually don't even line up with their symptoms just so that they can psychologically feel treated, etc. There is a lot of that goes on. One of the big measures of primary care reform, we went through it and created the family health team model that created more compensation for a doctor where they're paid on a per individual basis with some shadow billing fee for service. Physician compensation models are very complicated. It's a cottage industry in its own right, and now they go to arbitration every time. So I think it's gotten actually even more of a cottage industry. A lot of money to be made there for certain people, okay? I had the privilege of signing off on I think three different agreements, but we have a lot of resources. The Minister of Health in Ontario has the largest single budget in the country. Now, according to the Prime Minister's commitments to percentage GDP for NATO, maybe they'll be rivaled soon by the Department of National Defence, which is currently a piker compared to the Ontario Ministry of Health, heading towards $100 billion of annual budget, and huge proportions of it distributed with very limited influence. And the same thing that I said about the fragmented nature of primary care and EHRs or EMRs, it's there at the hospital level too. And, we don't get systematic performance for this as technological implementers, and it holds us back economically, health and social-wise, yes, but also economically. We haven't really seized. I don't know why I use the word seized, like I'm the son of a trucker. Seized is not good. Many, many different reports have been made that told the Ontario government or the hospitals how it's a model that allows a lot of localized power. Now, there is a lot of joint procurement. I'm not saying it's a complete hodgepodge, but it's even difficult to get systematic performance from dollars that you were the 90 some odd % provider of, etc. So we have a lot of opportunity yet to harness that massive public expenditure, nearly half of the provincial budget, and to create a much more dynamic, technology-inspired, where that healthcare system was actually the launching pad for technology. Imagine if we had that $100 billion of public expenditure tied into an Israeli mindset for innovation and implementation. It would be unbelievable, because in a way, one of the interesting things that goes on because we don't is that doctors, many of them are entrepreneurs. Even the doctor that's working in a hospital that didn't have that primary care clinic model that I was speaking to, every doctor has a side gig practically launching some X, Y, or Z. And imagine if that was actually a little bit more jointly harnessed. Anyway, lots of people have written about that. My friend Bill Charnetsky plowed away at that for several years in the provincial government. But it's the kind of thing where I'm not allowed to say this because people say, oh, well, you can't bang heads. Sometimes when I meet people from back then, they're like, oh, I was at a meeting with you in 2006. And I'm like, uh-oh, was it me or was it Furious George? But some of that was just an immature reaction to pressure. And some of that was designed by strategy, because if you want to get an inch or a quarter of a mile in a regulatory change where a regulated health profession is influenced by it or what have you, is like, you got to move heaven and earth. Like, even where you theoretically have a lot of power, it's very hard to move it. But Ontario, the government of Ontario, the Prime Minister, the federal work with Evan Solomon, there's yet for this massive public expenditure that we have, we are not reaping a lot of the economic benefits from it. We reap the economic benefits from having good health care that's not a big company expense. but we really haven't on the technology side, just scratching the surface.
That entire time, he just mentioned technology right now. At the very end, I'm laughing because with that question about, what do you think the barriers are? I was hoping I was teeing you up to talk about AI and technology adoption, etc. But you went off down the path that you know best, and I love that because long as I've been in healthcare, my perspective, like almost everybody I'm sure who's listening to this, is at the ground level, and you've got such an amazing system perspective, and you have an appreciation of the levers that get pushed and pulled and the unintended consequences of them and how all of these things fit together and things that I take for granted. Like, let's just make it easy for a doctor to give me a prescription over the phone. Don't make me come into the office for my child's cough and cold, and your insights into the unintended consequences of some of these decisions. I find that so insightful. Anyways, I am going to bring it back to the technology side for a moment. And as we do think about the office of the future, I was having a conversation with a doctor yesterday, family doc, and he's saying he's trying to keep his clinic practice down to about 20 hours a week because he's really interested in exploring everything that's going on around the space of traditional practice and looking at where is the future going. And he says the real value he's going to provide in the coming years as AI encroaches increasingly so into primary care is that 20% of his true subject matter expertise that really challenges the conventions, and it's the more edge type of cases. The normal conventional cases, that's going to be AI is going to handle that handedly. And I will say, when I talk about AI, and I'm curious, I want to get both of your perspectives on this as well. When I talk about AI, for me, that also includes robotics. It didn't used to, but today, modern robots are all driven by AI, and they are the physical manifestation. The old robots were clunky because they were pre-programmed. Today, robots can behave very much with the nuance of humans because, well, they have the self-learning capabilities. And so I'm putting that out there because I'm sure our conversation will, as we start talking about AI in the future of healthcare, what role will robots play as well in this brave new world?
I want to just say, well, I always have something to say. So Patricia, you're in charge. You can probably shut my mic off. But other than that, two things that I think of just with respect to robotics. If I go to the Swiss Chalet in Barrie, a robot brings me my food. Why is a doctor walking 35 or 60 meters, 14? Oh, they average 23 appointments, 46 times to come out to a waiting room to call in. I'm going to have a robot do that. Like, why wouldn't you? Doctor pushes the button when they're ready for the next one. Keep one thing in mind. The government's recent deal with the doctors, the family doctors, they call it FO Plus, Family Health Organization Plus, is moving more doctors back to the one issue per visit model. Now, I've enjoyed a different model in my family health team. It's more like I know I have 15 minutes and I can cover whatever ground I can cover. So, but I think that robots have a place to play even in that role. I really do think so. With respect to AI, I think we talked a lot about record sharing, EMRs, and stuff like that. But where I'm really super excited about the potential for it is in giving confidence around its monitoring capabilities for especially physically isolated, but not technology or humanly isolated. So where we have a model of care for older people which focuses on the lowest cost things like loneliness and isolation, in part through humans, but also by proactively leveraging technology so that they can, like I watched my stepmother get a new life when Alexa came into her life. Honestly, it was remarkable. And that's obviously low tech compared to what's possible today. But the monitoring aspect, where I guess you call that the ambient AI, where the possibility is there to monitor a person's breathing rate or to take note of a change in their gait during their nighttime walk to the bathroom, when we know that falls can be a death sentence for people of that age. That to me is super exciting, because I'm working in developing a proposal or a concept in the space of retirement that's focused in the community, that gives you the support and services that you might wish to get in an institution, but doesn't force you into the cohabitation model that some people, especially post-COVID, have been a little bit less interested in. And of course, the big question for a family to do that is like, well, my mom, what if she wanders off or what have you? And there's been so much advance in technology to actually protect against those risks, etc. I think it's creating much more of an insurance lifeline in a certain sense, or confidence lifeline for families to support those kind of decisions.
You're reminding me of such an important point, which is the ratio of where the healthcare costs go. I'm counting on you to keep me honest here, but I think it's like 95% of the costs go for 5% of the population, and that's mostly going to be the seniors. And and we can talk about my younger child with a cough, but in the big scheme of things, that doesn't have much of an impact on the healthcare system. It's our parents aging at
If
home.
you take your kid to the emergency room, which hundreds of thousands of Canadians would do on a yearly basis for what we call CTAC 4s and 5s, things that could be treated in another setting, that's a very expensive phenomenon. So I'm not trying to pull your situation, like I'm not trying to criticize that, but our emergency rooms, because a lot of people estimated not to have a doctor, a lot of them can't get the fast access that you're talking about. Like, oh, the cough will be over by the time I can get an appointment, might be a hint to people. But we really do burden our ERs yet with some of those challenges. I'm sorry to interrupt you, Adam.
I'm just thinking about, there's so many incredible technologies out there. There's fall detection software. I think it's Winterlight that has speech detection that detects Alzheimer far sooner than any other. You're nodding your head, Patricia. Good, you're keeping me honest here. Far earlier than other diagnosis. There's the fundus cameras that look into the microvasculature in the retina, and they can detect diabetes far sooner than anything else. I think you mentioned was your mother-in-law and how Alexa changed her life, and Alexa is baseline technology compared to some of the AI therapists, as well as just AI companions that we're starting to see come out. There's so much incredible technology, but these are all pockets of technology. And then there's the adoption curve, two different challenges. And so can we create a lab to, test these things out in the real world and work through the issues and the bugs in deployment before rolling them out? And I'm thinking back to the point about governance. When we do these massive rollouts, one, they have to be successful because there's just so much money and inertia behind it, and so the projects themselves become monsters in terms of scope, just on the basis of the gravity that they contain. Anyways, I love your idea of the innovative clinic, and I think we need to look at how can we create the lab, a sandbox type of environment to test that out in a safe way, but also in a way that allows us to fail without with doing minimal harm, but still going forward.
Oh, just one very quick point that's very relevant here. I was speaking to the founder of a robotics company that focuses on robotics within medicine. And I was getting some information about how the clinical trials work for robotics. Where do they find the people? And oftentimes you have to first start with cadavers, and then you move on to folks who are in countries where they can't necessarily afford medical care. So they will try this newer method on them with the agreement that they will pay for their medical care as a result of that. So it's the whole process of getting these robots approved as medical devices is still, I think, very novel and do require the kind of resources that are very difficult to acquire. I'm curious to hear what your thoughts are around that.
Well, my gut reaction is it's an ethical thin line to be moving from cadavers to testing on real humans in effectively third world countries, and I know the pharmaceutical world will sometimes do that as well before spending hundreds of millions of dollars on a phase 3 trial in a developed country, and I've always struggled with that, but the flip side of that is you're also bringing care to people who couldn't afford it otherwise. I guess I can rationalize, and as long as it's informed consent and there's transparency around it, but definitely it is an ethical consideration that I don't have a good answer.
I don't either fully, but Canada is a signatory to what I think is a treaty, some form of United Nations inspired agreement around ethical around health matters, kind of like ethical participation in those. Maybe somebody should just ask Premier Ford at a media event, and he'll make up a policy, and then they'll implement it, because that's happened before. It'll be very interesting to see. Just to talk a little bit about the interface with AI, in a way, like I was talking before about keeping seniors at home, the way that I imagine technology in that context is that it's leapfrogged to the point that grandma or great grandma has got such great technology that the grandson wants to go and see it, or he heard about it, or that it's voice activated, it's a large screen, it's whatever those things could be, is that it's grandma has leaped forward in a certain sense. And a second thing that I heard from a doctor, I follow on LinkedIn Keith Thompson, who's a doctor in the London area. I love the guy. I don't think I've personally met him, but I feel like I've hugged him. He's very inspiring, I find, because I don't think he ever stops working, and he certainly never stops learning. And he's applying AI in his practice, and he's telling all of us how that's going. Kind of with AI looking over his shoulder was the way I perceived it, etc. And I think it's really, really interesting to see that, in a certain sense, an upside of the model that I mentioned before, which is that thousands of these doctors in Ontario are actually operating in their own small businesses within the realm of their budget. And I'm not saying they're making tons of money like in the clinic, but they have the flexibility to choose those technology paths. The thing is, like, imagine that we took it one step further, which is that we used some of those people to actually help us decide which one of those technologies or which two of those technologies would be good for everybody. And then we found the means of systematic dissemination of that. We don't do that. There's very limited effort towards that, which tells me that in a world of constrained healthcare resources, if people think that we've seen budget constraint in healthcare, as Adam spoke about, in the last few years, that is nothing from what's coming. And I say that because the fiscal realities of Canada are being reset. Ontario's projection for budgetary increase for the Ministry of Health this year is 1 point something %, which is certainly lower than the hospital run rate, let's say. So that's a very challenging phenomenon. At the same time, we have more people, but especially we have more old people and more chronic disease people. The chronic disease group's very large as well, even if they're not old yet. And in a certain way, I might hope that the conditions are going to create more inspiration for customer improvement, patient outcome improvement, systematic performance, etc., driven by technology and the sheer reality of the need to try and take advantage of it. Now, alongside that, who's gonna protect that it's done in such a fashion that it actually does deliver something for patients and isn't just a way to fence them off from talking to a human.
I'm curious, Adam, given all of that, what do you think are the necessary steps to get the infrastructure set up to make it happen?
Earlier off the cuff, I threw out the idea of a sandbox type of environment. I'm going to stick with that for a little bit. I'm sure if I thought about it more thoroughly, that there's all sorts of holes that can be poked at it, and I know it's been tried before, but I do like that that concept. We are in an interesting time as well where healthcare evolves slowly on purpose because it's people's lives and people's health at risk if we move too quickly. You already brought up that point about the trials with robots in third world countries, and I got into debate the other day with someone about Neuralink, and this is Elon Musk's Neuralink, and it's done some wonderful things for people with paralysis, as I understand. But Elon has such incredible control over the media spin that what we hear is going to be just the favorable. And I know that from my time with clinical trials. As much as there's protections in place, we tried to bury the negative outcomes. And I was looking into Neuralink the other day, and one of the first things that came up on my feed was a whole long Reddit stream about some of the early testing done on primates, and it was quite negative. There are all sorts of adverse events and deaths, etc. And there's a cloud of questionability around it, where Neuralink is saying, well, these monkeys were terminal to begin with, and then the animal handlers who have left were saying no, their demise was as a result of Neuralink. It's a long-winded way to say I don't have a good answer, and I am not a medical ethicist, but I do know in the rush to adopt innovation, and I am such a strong believer in innovation and the importance of it for helping to keep the costs of our healthcare at an acceptable level for us to have a strong public healthcare system. But in that rush, we can't lose sight of the medical ethics. And fortunately, that's not my area of expertise. I'll leave that up to others.
I think that, to your question about infrastructure implementation, people come up to me all the time. I was just at the AMO conference with all the municipal leaders, and people have got all kinds of ideas. And whenever one of those ideas runs through a required signature from the Ministry of Health, I tell them to think again. Do you actually need them? Do you really want to put yourself in the 15 to 20 year queue for a small capital project? You have the power to leverage that yourself on a public-private basis or what have you. My mindset has changed to exactly the other side, even though I still have some of the institutional defensive response on issues, etc. Now I'm on the other side of it, where I know the limitations that they're facing there. And, leadership time and energy is always the thing in shortest supply. If the doctors have 17 hours a week of administration, you should imagine how many hours a week of administration the Minister of Health has. Significant portions of it justifying themselves to the central government, the Premier's office, Department of Finance, etc., etc. So the power is out there actually for significant portions of the publicly funded, universally accessible healthcare system to be the implementers that in a lot of cases they have quite a bit more liberation to do things that could be innovative. It could be research for that purpose. But I really try to say to people, don't look past the power that you have. Don't operate in an environment where you think somebody up the food chain necessarily has a better idea or what have you. And if you can implement this without getting a lot of signatures, then that might be to your benefit.
And do you think that it would be possible to implement a sandbox of the type that Adam is proposing?
I don't even know what that means.
Well, let me elaborate then.
Probably everybody else does. I'm not saying
No.
when
If
you
you
say
don't, I'm sure it requires elaboration. You've talked about your vision of to paraphrase lightly, a clinic of the future. One that's going to address the quadruple aim to a large degree. It's going to be heavily dependent on technology and AI. There will be some robotics in there, etc. And it's lower costs, better outcomes, better patient satisfaction, better doctor clinician satisfaction. The traditional adoption of technology in healthcare, as you pointed out, is what did they say? 17 years bench to bedside, and the AI is going to steamroll everything in 17 years. We can cut that down probably by a factor of 10. And so if we use traditional trials and as you're pointing out, signatures from a governance perspective and dissemination of knowledge to the front line and then adoption, the even 10 years from now, our world, I'm convinced our world's going to look drastically different. Google's Amy, a year or so ago, was demonstrating that compared to doctors, it's got better diagnosis, better therapeutic recommendations, and better empathy. That's a year ago. And AI is doubling it, depending on whose numbers you use, every 4 to 7 months. So even 2 years from now, the technology that we'll have as consumers is going to be in many respects much greater than what you can get by going to a primary care office. So we all use Dr. Google. We've been using Dr. Google for years. Now we're using Dr. Chat GPT for increasingly complex things. It's can you see it? I asked the other day, do I need to worry about this? No. It's an age mark. It's not malignant. We are adopting the technology in a consumer model. So in my mind, a lab is bringing in all of these advanced technologies and figuring out how to use them in a safe way within the system so that there is some appropriate oversight and there's some continuity of care. I don't know. Does that help, George? Does that help frame up?
I think, the way I would answer your question, Patricia, is it's very, very challenging to imagine this at a system level, but it's not that hard to imagine it at a very granular level. Out of the tens of, I don't know how many primary care practice environments there are in Canada, it must be, I know a lot of numbers. That one I don't know. I'm going to say 10,000. You can do this with 1 or 2. I don't know that you need, unless scale's a really important part of it, et cetera, et cetera. There are so many places out there that could be the sandbox. And there's going to be chunks of money, like government frequently doesn't have money to do everything, but they'll do a pilot. I tried hard not to do pilots that I knew I had no chance of implementing as a matter of practice. But now that I'm on the outside, I'm frequently recommending them to government in the hopes that someone will bite on the fact that it's a lower, it's like, well, we feel good, you know what I mean? So it's another example of how I shifted around. But sure, I think invariably you're going to see some really remarkable reorientations of family practice. And I don't know. I hope that with that on an Adam aided basis that we might be one of those trying to influence it, because it's so needed and it's so fascinating and it's such a remarkable opportunity in the grand scheme of things, where largely speaking the funding is already deployed. But I know there will be a lot of people thinking similarly.
I think it's a brilliant idea, and if the law allows it, if it doesn't allow it, we should definitely change it. And if it does, it would be great to see it actually implemented.
What law wouldn't allow it? Like, you're the specialist in law, like health privacy as an example. What law wouldn't allow it?
I wouldn't
What are
call
the other?
myself a specialist in health privacy, yes, but not in law in
Well,
general.
it's a law. I was just making the point. It's one of
Yes, that
those.
is
It's
in
one of
that
those
one.
most quoted laws in healthcare. So it's a
Indeed.
good starting point.
There's a lot around medical device approval, and I would be interested in knowing whether there's any medical device approvals necessary in order to implement these devices in a sandbox environment if you're actually providing care to patients. So basically, if the approval process is too cumbersome, or if there's an easy way to enable it, or if it would completely block this idea.
Well, I'll say this. If you really wanted to rush to market, one could go to the US, where the regulations are being eroded on a daily basis, and you could probably do this there. And even where the laws are still exist on the book, I think in the race for innovation, and particularly anything AI related, the federal law is going to protect the innovators over the patients. If we were, for example, to take a robotic type of intervention, a device intervention that historically would require all sorts of FDA approvals and still does require FDA approvals, we could deploy it there, and I would feel a lot more comfortable doing that from a legal risk perspective. Now, I'm not saying that that's the right thing to do, and I would not want to do that because that crosses my own personal ethical boundaries.
I don't follow that line of thought, honestly. And also, when I'm talking about primary care practices, I can't imagine what are these human interfacing medical devices that I'm going to be applying there? The robot I imagined was a service robot that, brought you a cup of water or told you that Dr.
Yeah.
Thingamabobber could see you now. So I think a lot of the primary care piece is figuring out the privacy, the appropriate protections for privacy, is how do you blend these two things that we really, really want? Very, very secure protection of our most precious information. And that's what scares the shit out of me about Neuralink, because I've typed, even yesterday, very, very long or very spicy social media responses to things that I thought were stupid or what have you. Well, I frequently don't send those, not because I don't feel that, but because I don't really have the energy to defend it from the people that I'm going to arouse. So in a Neuralink world, I kind of think of it like that's getting into my thoughts. I've written letters that I never sent, and I have thoughts that I've never articulated. And frequently, part of my gift in politics was swallowing what I was about to say in favor of the next thought. And I got that didn't work that didn't work all the time either, but it's like, oh, good thing I didn't go down that path, et cetera, et cetera. So that's what scares me about Neuralink. But I think in this case, we want to protect that information, but at the same time, if you ask a patient, like, would you feel better if your physician was operating in a way where he took your conditions and lined those up with global databases of people that have faced exactly the same situation as you have to try and get some insights into practice modalities or best practices or what have you?
So hey,
why wouldn't we aspire to that? Now,
so hey,
Patricia, you have
George.
to show me. Yeah.
No, I was just going to say, let's agree on that because I totally 110% agree with you. So what I think we need to do is draw a boundary between what is low risk and we're comfortable working with and what is potentially a high risk. And a high risk might not even be necessarily obvious, but it's where those unintended consequences may come out. And uh, I'll give a real world example and then parlay it into into a potential hypothetical. The real world example is Atomic Energy Canada a number of years ago created a radiology chemotherapy machine. I think it was called the Therac 27. I'm probably off on the name. And wonderful machine at providing therapeutic radiation. It had a flaw in the software and it wound up killing patients inadvertently, of course. Unintended consequence. We could, as we're going to start off with robots that escort patients to the waiting room and deliver, glass of water or what have you. It's going to evolve from there. Next thing it's going to be doing is taking over the role of some of the phlebotomists and doing blood draws and possibly doing screenings for blood sugars and it's going to be delivering medicines as well.
I don't want to come off as a robotics Luddite. My point was I don't see as much of it in primary care. But as back in the day, even when I was Minister of Health, I think at London Health Sciences or at the University of Western Ontario, they were showing me robotics. We've practiced operations from Toronto for people like I'm all for it there. I see that a little bit more on the hospital side. That might be limited thinking on my part about what the possibilities are, because there are more and more community-based functions. I was thinking a little bit more in the primary care office is that protection
Yeah.
that protection and the walling off. And that's sort of like that I told you, Patricia, that's when I first met you. I was like, I need to get to know this woman better, because that's a really tricky bit of business to be able to do it in a fashion where you're not set up with the risk of unintended consequences, because no lawyer that's where you're going to run into is like, well, I really want to try this and I'm going to get the consent of my patients. And some lawyer is going to say, yeah, well, they're not allowed to give away their consent for you to break the law, or something $800 an hour worth would produce over 6 or 8 pages. But that would be, to me, to my layman's ear, what I imagine to be kind of the constraint here, etc. So to me, that's a tricky bit of business, but fascinating. And I know that Patricia's essential to figuring that out.
Good. Well,
Or the AI that she relies upon. I don't know.
well, and George, I know this won't come as a surprise to you as I'm listening to you. To your response, I got to point out, I do side with you as much as I'm playing devil's advocate on the protection side. I really do want to see technology get adopted faster. And what won't come as a surprise to you is, possibly one way to do this is with that independent oversight board. If we're going to develop a clinic, we will be incentivized to move quickly, and we may not always be consciously aware of things that we would be if we were scrutinizing it from the outside. And so you're nodding your head no. Okay, go.
No, I'm going to say,
Let's have it.
money is power. That's all I'm going to say. Money is power. And oversight board in the vortex of alphabet soup of acronyms in the healthcare sector, like, I don't know. I really don't know. So, but the good part about it is, like, the rapid evolution of technology that you speak to, saving the devices piece, which could be more complicated as we've discussed. There are limited governmental barriers to that if you're practicing within the environment that protects people's personal data. I could say it like that. And I think, like, look at my situation. I'm a patient. My family is of the family health team at St. Michael's Hospital, now called Unity Health by some, that is affiliated as a teaching hospital with the University of Toronto, which I think is trying to stake out a fair reputation in innovation around AI, if I have that right. How long is it going to be before somebody at U of T is cooking up the idea that they need to turn one of the many practice sites in primary care that they influence into a lab? Like, if the will is there, we do have a lot of pieces of the puzzle that could come into it. But I kind of think is like, maybe the university thinkers are going to be the ones that push this out to implementation in healthcare. And we have a dreadful record as a country at uptake of new technology. And, I think if you talk to people from those med device companies or even pharmaceutical companies, Canada is not in the upper tier list of offerings. Sometimes we're implementing stuff 2 or 3 years later than others. Imagine if we were like that on the vaccines, where we got ourselves pretty close to the front of the line, like, well played. But in lots of other ways, we're very, very deficient in this matter. But I just point to that as, like, I could be depressed about that, but I actually see a lot of opportunity in that, as Canada has to dig harder to figure out, is like, what are the products we're going to make here and sell to the rest of the world as we rethink these things, that there is a significant opportunity to do, more with that $100 billion. I'm only talking about Ontario public healthcare spending, not the billions and billions of private healthcare spending by, and not talking about all those other provinces as well, or the federal government and what it spends on veterans and for Indigenous people, etc. We have an extraordinary laboratory as a country that's devoting such a large proportion of our public commitment to healthcare. It's time to leverage that for economic for patient benefit, primary motivation, of course, for better flow in healthcare, for more efficiency of the time of the costly practitioners, but sell it to the world.
No, gentlemen, we are at time. Any final thoughts? Anything you want to tell our audience with regards to how to get in touch with you? If there's anything they care to share.
Well, you can find me on LinkedIn and Facebook, or you can email me at george@georgesmitherman.com.
And similarly, well, you can find me on LinkedIn as well, not on Facebook, and email adam@adamcole.ca.
Thank you so much for your time. This has been a really fun conversation.
Thank you,
fun for us
Patricia and
too, I'm sure.
George.
Thank you. It was my pleasure. Have yourselves a great day.
Thanks for listening. Before you go, a quick note about the company I co-founded, Private AI. We help organizations use their data safely so they can build compliant AI products, share data securely, and extract insights without the regulatory headaches. If PII, PHI, or PCI data are standing between you and your next innovation, visit private-ai.com. See you next time on the Data Frontier.